Hello, everyone. We will be starting very shortly, just giving our audience a couple of minutes to settle in. So, welcome, everybody. Welcome to Tackling Gender-Based Violence in Public Health Workplaces in India. This is a part of WomenLift Health's ongoing campaign for the 16 days of activism against gender-based violence. Um, Maybe a lot of you are already familiar with WomenLift Health and the work that we are doing, but for those of you who aren't, we are working around the world to expand the power and influence of women leaders to transform health outcomes for women, girls, and vulnerable populations, and be change agents for inclusive leadership. We are working at regional hubs in East Africa, Southern Africa, North America, and India. And we work to develop contextualized leadership development programs for thousands of mid to senior women leaders working in public health and global health. Today's event is, as I said, a part of our ongoing campaign for the 16 days of activism. This issue of gender-based violence is particularly pertinent in India, especially in light of recent events that have taken place in public health settings in India. We've put together a panel to unpack the different manifestations, both overt and subtle, of gender-based violence at the workplace and explore ways in which institutions can address these issues and create safer, more inclusive environments for women. So just a brief overview of how the next hour is going to look. This webinar is going to have two parts. We're going to start with a moderated discussion among our panelists for around 40 minutes or so. And we do have some time towards the end for taking questions from our audience. You will notice that our Q&A box is enabled, so you can submit any question that you have by typing it into the Zoom Q&A box. Feel free to submit your questions to the session, and all questions will be taken towards the end once we're done with the moderated discussion. And this particular session is also going to be recorded. I'll start with a few speaker introductions before we can kick things off. So today, to take on this very, very urgent topic, we are joined by women leaders across India's health ecosystem, and they are also a part of the Women Lift community in India. So we are joined by Dr. Manisha Gupte today. She has been a part of the feminist and health movement since the 1970s. She has extensive experience and has co-founded MASUM, a rural women's organization, in 1987. She is also a mentor for our leadership development programs in India. So we're very glad to have her join us today. We also have Monalisha Sahu. Dr. Monalisha is an associate professor and head of occupational health at the All India Institute of Hygiene and Public Health, Kolkata, under the Ministry of Health and Family Welfare. She's also a core committee member at the National Human Rights Commission and serves on internal complaints committees for institutions under the Ministries of Health and Family Welfare and Labor and Employment. She is also a current cohort member of our ongoing 2024 India Leadership Journey. Along with Monalisha, we also have Priya Das. Dr. Priya Das is the Gender Global Focal Point and Gender and Health Lead at Oxford Policy Management, New Delhi. She has over 20 years of experience working on gender-related policy and research in the development sector in India. And finally, our moderator for today is Dr. Shubha Nagesh. She is the Advocacy Advisor for Global Health at the Women in Global Health and is also the Alumnae Lead for WomenLift Health in India. And I think without further ado, I'm going to hand it over to Shubha, who is going to be taking us through the discussion for the next part of the webinar. Shubha, all yours.
Thank you so much, Sanaya. A very good evening to all of you. We are truly excited that you're joining us today for this crucial conversation. This panel, like Sanaya said, brings together 3 experts who have been working to create safer, more inclusive, and more equitable environments in healthcare and in public health systems. So we hope this will inspire some fresh thinking, foster some fresh collaboration, and will also help us all understand how we can contribute to ending gender-based violence in the work space that we occupy. So without further delay, I would first like to invite Priya Das, who's the Gender and Health Lead at Oxford Policy Management. So welcome, Priya. Our question for you today is, given your expertise in women and girls empowerment and gender-based violence, could you share some of your insights on the continuum of GBV? So from the more subtle microaggressions to the more overt forms of sexual exploitation and abuse. Over to you, Priya.
Thank you, Shubha. So, while it is the 16 days of activism, and we think of gender-based violence as very overt physical forms of violence that we, most recently, Sanaya was referring to the Calcutta scenario. But what I want to talk about is how we really create those conditions, right? And build those environments where these extreme forms of violence takes place. And that really starts with the everyday micro practices and behavior of microaggression that takes place at the workplace. There are some very overt hostile forms of microaggression and practices, etc. But then there are also much more subtle forms of aggression that eventually have very, very profound impact in terms of the violence that they perpetrate. And we also need to understand that in the context of a much broader definition of what is gender-based violence. At the most elemental level, we think of it as violence perpetrated against an individual because of their gender and disproportionately affects them, their families, and their communities. But also to understand that gender-based violence is not just physical. A lot of you already know it's emotional, psychological, economic, etc. And these microaggression that I'm talking about, of course, it is everyday forms of sexism, behavioral issue, practice, etc., which often just kind of creates that environment, which on a daily basis, like, somebody said that death by 1,000 cuts, like we're consistently demeaning, putting down, undermining, the group against whom we are perpetuating the violence. Of course, perhaps in this context today, we will be speaking more in terms of gender binary, but it is, gender-based violence is violence against all forms of gender. I just want to basically, in the time that I have, share very concrete 3 examples that I have come across, which to me, overtly, and even to the people involved, may not seem as the most obvious forms of violence, but has very, very sort of profound impact in terms of economic, psychological, etc. And I just want to, the first example I want to talk about is, like, let's think of, in the context of what happened in Calcutta, and it was never the first and not will it be the last. What kind of gender responsive infrastructure do we create in our health systems or in any workplaces, right? Very recently, we put together a guidance book, and we drew really from all the national guidelines and QAS for health systems, etc., and the international ones. And there are more than enough provisions there, but very limited application of that, right? If you're not going to have separate toilets for women healthcare workers and health systems, and they are going to use the general toilets, if you're not going to have enough lighting, if you're not going to, sort of shove them in corners and spaces and sort of dark places, if you're going to make them sit around, nursing stations, which has no ventilation, all of this is kind of perpetuating a culture where we are saying that, how we value these people and what's, what kind of behavior and practices are okay for them. And to take it to a next extreme, I mean, at some point in time, 2 years ago, we did a research around health and gender, and we spoke to the nursing community. And what was shocking, actually not so shocking really, but I should have expected that. We know that there's an extremely sort of limited implementation of POSH across, right? We don't, I mean, WCD is supposed to sort of publish the monitoring report. I don't think we have that monitoring report yet. But what I learned is that when any of the nursing community makes a complaint around sexual harassment, there are only two options. That you keep quiet about it and take a great recommendation and move away, or you don't keep quiet, you still have to leave without recommendation, right? So if we are going to follow this culture and this sort of conditions, it won't be it's not surprising why sexual harassment and exploitation continues, and sometimes it blows out of proportion to take extreme physical forms where it starts attracting attention. But the starting point is not when the violence was perpetrated. Violence is perpetrated every day through systemic practices and policies, right? The second one that I wanted to share was in terms of economic violence and career growth. Very recently, I had visited a medical college in one part of India, and I was sort of having a chat with the interns there and the medical students. And one of the things they told me that a part of their course is to really go and do night duties at the district hospital. But very much part of what we call, the protectionism or the benevolent sexism, because the institution wants to protect the women, women interns and students are not allowed to go and do that. Only men are allowed to go. They don't think of how the system or the institution can provide safe transport, etc. It's just that, well, we don't have the resources, let's not allow them to go. And very clearly they said that when they move into the professional space, their experience at a district hospital is going to count towards their merit and therefore their recruitment and positioning. So again, this doesn't seem like violence, right? But eventually it's going to affect them in terms of their career growth, etc., right? And then there are the most obvious sort of forms of structural forms that is perpetuated through everyday practices. If we look at the hierarchy within the health system, for instance, right? You have the nurses, yes, professionally, they may be at the lower sort of rank, but that is their profession, but that does not mean they should be given the right due respect or shouldn't be given the position or the rights that is due to them. The whole sort of treatment, behavior, working environment, all of that just tells the larger audience and the larger ecosystem within that system that, we do anything to them, it shouldn't really matter. So to end, I just want to say that really to understand gender-based violence much more from understanding, the continuum of where it begins and then eventually where it ends up. And rather than really looking at the symptoms, it's important that we start addressing the causal roots of it. And I think I'll stop there. Thank you.
Thank you so much, Priya. I think the examples you shared have set the tone for the rest of this webinar. So thank you so much for sharing your insights. Next up, I would like to invite Monalisha Sahu, who's Associate Professor at the All India Institute of Hygiene and Public Health. So Monalisha, a question to you is, as a public health practitioner, could you share some of your experiences with GBV in healthcare settings? What are some of the common forms it takes in hospitals, and what gaps do you see in public health infrastructure when it comes to GBV? Over to you, Monalisha.
So first of all, thank you, Shubha. And I really congratulate WomenLift Health for their unwavering commitment to amplify voices of women and girls towards combating gender-based violence and observing this 16 days of activism. And as you asked, Shubha, that as a public health practitioner, yes, unfortunately, I would say, like Priya said also, that I have witnessed various kinds and various forms of gender-based violence in hospitals and public health settings and in organizations, which are ranging not only which are not only physical in nature, but physical or sexual, but also emotional and economical and psychological. So every aspect of it. And of course, it is ranging from subtle microaggression, gender discrimination to sexualized verbal abuse, harassment, physical violence, and of course, overt sexual harassment, violence, rapes, and murders, you know. So every day we just rise up to a new horrifying story. And with the recent Kolkata case also, we all are aware of, but even before that, so, and though the stories are harrowing, but what is worth pondering that while overt acts of sexual harassment and this kind of assaults and abuse is creating only 30 to 40% at the max cases of overall GBV, but this microaggression and gender discrimination, this is causing a larger part of it. You know, so it is embedded in our day-to-day lives, like Shubha also mentioned, from, I would say, like very dismissive comments, like when we were, I clearly remember when we were when we qualified NEET and we appeared for our like PG counseling. So it was like, there were some men who were suggesting that why one of my colleagues, she was about to take a surgical branch, you know, so orthopedics or let's say a core surgery branch. And she was advised that why are you wasting this seat? Why you don't take a seat which is more suitable? Like anyways, you should uh, take something which is more appropriate, no? Why don't you go for obs gynae, or why don't you go for dermatology? That will be easier to you. That will be on easier to you. That will help you with your family responsibilities. So ranging from there, and then again, like Priya mentioned, the job opportunities. Yes, so many of the private hospital, when the health workers or the doctors, even they want to join, just they prefer male doctors or male health workers because they're not able to provide the kind of security that is needed, and it is much of trouble for the management. And if they are women, they will go for let's say maternity leave. There will be 10 kinds of responsibility with childcare and everything. So why to hire women, you know? So despite of being so highly qualified, their opportunities are limited, and that is in some way it is advantageous to their male counterpart because their career progression in that range, it is just advantageous to them. I remember one of my professor, I won't quote his name, but he used to say that till MBBS you will see that uh, there are women who are the toppers, you know, if I'm just talking about academics, let's say. So in most of the batches, so the women, they are doing well clinically as well as theoretically. But after a certain time, like post their postgraduate degree, so everywhere you will see that it is their men counterpart, which who are performing better and who are getting better opportunities. So why is it so? So this is because of this whole systemic uh, structure which Priya was talking about. And it is not like only it is patriarchy. Sometimes like women, they are also the perpetrators. I have heard some fellow women also, I have witnessed one case in which one fellow woman, because she was not in good terms with the other women professionally, so when she was posted at periphery, she made some kind of remark that I hope that she gets raped in the periphery. So even such kind of so overt and blunt and insensitive remarks can be made by a women colleague. So we can totally understand that it is not only coming from workplace, but it has deeper role in our societal roles and the gender approaches, where for everything is seen through a gendered glass, and women are also given responsibilities which are very much gendered roles. Like if there is something related to cleanliness, something is related to arranging food, or just giving word of thanks, or just introducing or anchoring. So all these kind of responsibilities, many a times they are given to women, and more technical and creamy and uh, things with graver concerns, they are taken by their men counterpart. And also that is one reason that there is this vertical occupational segregation, So what is this vertical occupational segregation? That worldwide, globally, 70% of the health workers, they are women. So the healthcare is being delivered by females, but the healthcare is being led by men. So that is a very sad part about it. And the most concerning aspect of it is the normalization. Like it is always, whenever these microaggressions they are talked about, it is often brushed under the carpet as a professional banter and just the way things are. And this normalization culture, it creates a culture of silence. So when we are talking about what is lacking, so many things they are lacking currently in the public health system, and first and foremost is a safe environment and clearer policies. So there are no clearer policies of though there exist posh guidelines, but to it is mostly uh, clear on what if the perpetrator has done something which is more physical or sexual, but let's say microaggression and gender-based discrimination. So for these kind of things, there are like very thin boundaries, like we were discussing also the other day. And then many of the women colleagues, they're not even aware where to complain, and they don't feel it safe, because it is women who is always blamed, and she has to take on the shame on her own shoulder even if she complains. So there are no supportive measures, there are safety measures lacking, there are no counseling services to provide her with mental support. And also gender inclusivity and also diversity, it is also a very less talked about, still it is a very less talked about agendas in most of the healthcare settings. So I think with time there should be multi-pronged approach which will deal with all of this, and there should be trainings not just for the sake of the training, and not just for just covering the quota, but actually making people aware. So yeah.
Thank you so much, Monalisha. You brought in so much into the conversation. And this sort of leads me to what I wanted to share next about one of Women in Global Health reports, which was released at some point last year, which is called Her Story, Ending Sexual Violence and Harassment of Women Health Workers. So this report was actually the result of the Health2 research project and an online platform.
Yeah.
It highlights the pervasive issue of sexual violence and harassment, which is faced by women health workers worldwide. But due to the lack of comprehensive data on SIA in health, this report actually drew on the testimonies of women from more than 40 countries, which was collected in about 10 different languages. And the whole idea was to sort of bring light to the nature of the problem and the conditions that enable it. So while SIA in health is a global issue, the legal, the cultural, and the socio-economic contexts vary across regions, across countries, and even within countries. So this report really emphasized that solutions need to be tailored to each country's unique situation through common principles that can guide action. And key recommendations included holding perpetrators accountable by ensuring that shame and blame fall on them and not on the victims, that strengthening organizational leadership to prioritize gender parity and to address gender inequality is important. And leaders, particularly men, must take responsibility for driving change and to foster a safe environment for women health workers. And the report also advocates for a survivor-centered approach where women's voices are heard, their rights are protected. It calls for better legal frameworks to safeguard women workers and urging all countries to ratify the ILO Convention 190, which addresses work-related violence and harassment. Data collection on the prevalence of CR remains a significant challenge. And so this report also called for international agencies like WHO and ILO to collaborate and make member states and organizations to establish standards, to collect sex disaggregated data, all of this which could help make this abuse visible and more measurable. And by amplifying the voices of women and for pushing for systemic change, this report also calls for an end to sexual violence and harassment in the health sector. With that, I would now like to invite Manisha Gupte, who is the founder of Mahila, Sarvangeen, Utkarsh, Mandal, or MASUM. So Manisha, what I would like to ask you is, as someone who's deeply involved in women's rights and addressing gender-based violence in the communities you serve, could you speak to how systemic this issue is? And what are some of the broader consequences of neglecting women's safety? Over to you, Manisha.
Thank you, Shubha. Thank you, WomenLift Health team for holding this webinar. And I want to start off with remembering Dr. Ambedkar, because of whose leadership all of us, at least theoretically, have equal rights irrespective of gender, caste, class, etc. So starting off from where our health workers come from, especially since I'm a community person, so I'm talking more of community level health workers. They come from society, right? And so therefore, the continuum of the work that women have to do. So lives being artificially divided into the private and the public domain is one of the major structural reasons why women suffer discrimination and violence both inside and outside the house. So for example, if a woman is working at home, unpaid, unrecognized, unappreciated, that home doesn't belong to her, right? So she's actually working there. If she's in the fields of the family, she's actually just an unpaid person on that work. Where she's going to collect water or fuel. All these are, are they public places? Are they workplaces? Are they home places? So it's all health workers come from these spaces. So if an Asha is talking to a survivor of gender-based violence or asking a mother to come for immunization of a child, and she's doing it at the flour mill, then is that her workplace or is that not her workplace? And so therefore, these completely fuzzy boundaries where say the Asha is in someone else's home. Okay, so now that's the public domain, that's her workplace. For the woman where she is, that is her private domain. So therefore, I think one of the structural reasons is the artificial divide between these two domains, so that public and private patriarchies can seemingly act independently, but actually work together to disenfranchise women everywhere that they go, including largely the workspace, if at all women do come to a place where they have gainful employment. Now we know that work from home is quite different for men and for women. We saw that during COVID. We saw that's become the norm in many institutions. People don't want to invest in places, etc., whatever be the reasons. And that we find that, looking after the elderly, looking after ill, and this ties in with what earlier both my co-panelists have talked about the fact that you are expected to be working from 9 to 5. So you do dermatology, you do radiology, don't be a surgeon. If you're a dentist, don't be a dental surgeon, etc. So you are out there, you prepared home, you've done the homework, you've done the cooking, you looked after everybody. And then in your spare time, because a woman is expected to be primarily inside the house, and that is, if she's able to do all that, then she can go out and work. This guilt continues because women reach the workplace much later than men do. Many times, even women doctors, I know friends who've given up their careers for 10 or 15 years to stay back so that their surgeon husbands are able to perform in the hospital. So imagine what happens when you come back 5 or 10 years later, when you stay there erratically, when there are no systems in place in terms of maternity benefits, etc., or there is, misogyny or there is sexism in the workplace that you have, the microaggression that both my colleagues have talked about earlier. So this is what it is, that men, the workspace is being actually thought of as belonging to men. And so therefore you have, I just recently visited a primary health center in Maharashtra state, and the doctors also did not have a washroom. So can you imagine what happens to other health workers? What happens to women patients who come there? They had to go to some nurses' quarters and away from the PHC. So structural violence, as Johan Galtung talks of, he talks of structural, which is within the structures, and I'll come there in a minute. Then the covert violence, that of the family expectations, and then the overt, which he talks of as structural, cultural, and individual. So many times individual violence is relatively easier to identify the perpetrator. But the others are very difficult. And what can we do? These are big structures. We can't deal with them. So that becomes that's how the buck keeps getting in past. Now the hierarchies of class, caste, disability, marital status, religion, gender, sexuality, etc. Let's see where the doctors come from. Let's see where the health workers come from. So what is the hegemonic positioning of surgeons versus, say, a professor of PSM? So all these different, who has the power? We know as feminists that violence happens because of power and control. And so therefore, who can perpetuate violence against somebody? Those who are already marginalized, those who are already subordinated, excluded. So that's the way that violence happens. So the violence is basically there in the structures, and we would be surprised if we did not see the violence. Men obviously having advantage over women in terms of coming early into the workforce, being recognized much better. Now, why do health workers, why do women health workers or healthcare providers have to marry? Because that's the social expectation. No inheritance in the mother's house leaves women with no choice but to get married, to create this unbroken line of sons in the patriarchal family. So you get married, you bear children, and since that is considered your basic role, everything else happens around that. Added to which, if you do complain of sexual harassment on the bus, on the train, at the workplace, anywhere, the first thing is just stop it. Because anyway, patriarchy wants to control mobility. They want to control production, reproduction, etc. Right? So the first chance that the family gets to ask you is to leave. So you bear sexual harassment or violence, and you don't raise it at that time because you will be called in. But if you do not raise it at that time, then the suspicion, again, the suspicious husband, you didn't raise it earlier. That's what the workforce says too. And the husband also, you didn't raise it the first 5 times. So who am I to believe? I've seen in terms of targets, when ANMs or, village level health workers are forced to bring in, how did you get this extra money? Who gave you the money? Or why didn't you get the money? Why are you with this driver, with this doctor? In the bus. So all these are the situations in which women are grappling and cannot talk of sexual harassment. The conservatism in terms of control over daughters, control over sisters, all these become issues. And if we don't take care of safety, then the first thing that happens is take the woman out of education, take the woman out of the workforce. And then if she's not married, get her married, or say that, well, this was enough. Now, get back to your domestic duties. We did safety mapping of girls, not actually healthcare providers. And we found that the same places are gendered. If, there's a college, then the parking lot, the boys find unsafe because of maybe gang wars. Many times they're over girls who don't even know that the fight is happening because of me. For women, for girls, it's just because the men were there. For the same road, if it's deserted, it's dangerous. If it's too crowded, it's dangerous. Inside the house, it's dangerous. Yeah, Shubha, finish in 1 minute. Thank you very much. And so this is the situation of people now. One structural violence. If I cannot be open about, say, my gender identity, or if there are no ramps or no safe transport, if I have any kind of disability, or I have to hide my sexuality, or the kinds of schisms of religion, the kind of food that I have to bring, there. I cannot bring all the food that I cook because some people will be offended with the kind of food that I bring. So how do I cook different meals? And the last point that I want to make here is that let's not forget that it is the village leader who has to face the community. You announce scheme somewhere, but that scheme doesn't work at the village level. You announce some policy and say this is the amount of money somebody is going to get, but that money doesn't come there. The targets. So the woman who belongs to that community actually has conflict with the community all the time, and her life in terms of even going to fill water or going to the well, for whatever, to wash vessels, is affected because people look at her suspiciously and constantly have a litany of complaints against her. So when the workplace and the home are not very clearly divided, or they are divided by such huge schisms that women cannot even go there, and once they go there are not safe, all these add to further discrimination and misogyny. Thank you.
Thank you so much, Manisha. So much substance in what you shared with us. Really, really grateful for all those insights based on your experience at MASUM. Next, we have the same question for all three of you. So we will again go in the same order. We will get Priya to come in first, followed by Manisha, Monalisha, and then Manisha. So our question really is, what are some of the key approaches to ensuring the safety of ways to culture and behavioral shifts? Where do we begin, and how can we actually start making some meaningful progress? So first up, Priya.
Okay. So of course, this is a very big question, and it's fairly there are no easy answers, and it's complex. But I think in my limited understanding of where things need to move is both at the individual and the institutional level. Like I said, at the conditions and the culture of workplaces is where we allow the incubation and the perpetuation of the kinds of violences that all of my colleagues have been speaking about and I spoke about earlier. And therefore, I think, at least minimally, and I speak as part of the WomenLift Health cohort. What I have seen, at least in the implementation of POSH or in any other forms, is that it has a clear link to leadership, right? This whole benevolent sexism, all sorts of things are somewhere sort of allowed by the kind of leaderships we have. And even in non-health spaces, workspaces, of course, we all have all kinds of policies within our organization that we have to comply with. And it's always sort of a box ticking exercise. And we see, like, particularly for POSH, we see who's nominated. Women are nominated who will comply with the higher leadership. So I think one thing that anyway we are in the process through programs like WomenLift Health is to now begin to change that leadership. And when I say leadership, it doesn't mean that we make more just keeping women leaders will solve the problem. Like when expert one shared with me that more women leaders are necessary, but not sufficient. We need more leaders and more women leaders to be much, much more gender responsive in that sense, right? And then it comes down to us as who will our current leaders, future leaders, to really call out some of these things, insist on the implementation of the provisions we have. And unfortunately, also be ready for some of the consequences for being called the most difficult person or the, somebody who is constantly bringing things out, and sometimes also having to bear even more adverse consequences of, very casually and gradually you're being let go of the workforces. Because anyway, I don't think anybody's going to come around and give the marginalized or women or other, marginalized groups their rights on a platter. Some people have to speak up and ask and fight and get branded, but that's where kind of the journey will begin. But at a very, very practical level, I think that all of us at least need to be aware of what the provisions are, what provisions are missing, and become that voice and that advocate for the self and for our colleagues. And also the last point I wanted to make was that, this whole idea of women being women's worst enemy, I think somewhere as women, we need to really rethink that, because patriarchy, one, is a system. So it doesn't matter who carries it. It can be a man or woman. Two, women often get appropriated with the system and are used as soft targets, right? So I think we need to understand, that we need to stand up and support each other and sort of, take this forward together and not fall into the trap of women are women's worst enemy. Thank you.
Thanks, Priya. Thank you for spotlighting leadership in the context of this conversation. It's such an important dimension you brought forth. Now over to you, Monalisha.
So, thank you, Shubha. I will like to discuss it more in the context of public health system and hospitals and organizations. So firstly, and the most important one I feel is the robust reporting mechanisms and also a very clear grievance redressal procedures, because most of the times what I hear is that I do not know what to do. I do not know where to report. I do not know whether it will come under POSH or not. So if we have very robust reporting mechanisms and clear grievance redressal procedures, it is going to help not in the not only for women, but it will also help men, because I have seen that there are many work related harassment cases which are sometimes falsely classified under POSH, and because women do not get any other opportunities sometimes to report it, it comes under POSH many a time. So having more clear mechanisms and more clear designations of different different situations which will help in redressal. Secondly, there is critical need for comprehensive training programs, not only for GBV, but also, like I said earlier, also that bystander intervention, what should be there, or there should be gender and inclusivity and diversity trainings. So, and thirdly, creating a very supportive environment and inclusive environment, which can be brought in by, as Priya mentioned, that more women should be there in leadership, and more gender sensitive, more gender responsive women should be in leadership. Then there should be counselors and zero tolerance policies against GBV, and also there should be sections which are especially the policies which are dealing with this gender discrimination part, which is like the major proportion of all. And training and unreported, and the cases should not go unreported or unheard due to fear of retribution, lack of legal protection, and kind of systematic failure. So then another very important factor is having safety measures like CCTV camera surveillance and security staff, especially female security staff, and better lighting, better restrooms, so that women and junior, especially nurses and junior doctors, who often face harassment, especially in isolated wards or in night shift or in male wards. So these glaring gaps in safety protocols, they are to be filled. And ultimately, addressing GBV in public health workplaces would require a multi-pronged approach at the societal level. There should be a systemic response with institutional reforms and the zero tolerance policy against gender-based violence. So I think these are the call of the hours, and at least these things must be taken care before we can move any forward for like equity, let's say. Yes, thank you.
Thank you, Monalisha. You shared like a whole plethora of dimensions or solutions that we could use to address this. Over to you, Manisha.
So, if we want women to be able to take up leadership roles at the workplace, then men's participation inside the house has to be increased, right? What's happened is that women have taken on work at home and work outside the home as well. And they're in both the domains, private and public. But men have not entered the private domain with humility and with the wanting to really participate in childcare, cooking, looking after the elderly, ill, etc. So I've seen, since we're talking of public health, therefore it's not just related to the clinic setting, institutions related to policy, advocacy, research, etc. Men kind of breeze in, come in, I'm not talking about men, but very senior leadership also, and then they hang on until 9 o'clock, 10 o'clock. And if women leave around 7 o'clock, everybody's frowning. Why are they going back home? Well, women can't hang on, not only because of the lack of safety of travel, but they're expected to be home. And in fact, when I was doing training of very senior leadership of a big organization, I asked the question and I said that you can hang out here until very late evening, because your home is being taken care of by the women of your household. Yeah. So therefore, the workspaces have to become much more equitable in terms of gender. Systems need to be in place, so it's not just a good leader comes and goes. It has to be in the standard operating policies, maternity benefits, whether you have the POSH or other grievance redressal systems in place. Do you have a creche? Are there well lit and safe bathrooms? Is there enough water, safe transport, etc.? And for health workers, healthcare providers, it's from the center to the state to the district to the block level to the village level. That's how it is. And as you come down, power is much more disproportionately held by those who are there, who don't often have a full understanding of what happens actually at the interface of health care providers with the community. So therefore, what we need to do is to challenge patriarchy wherever we are. Not to have it. So there's, if the POSH Act, don't let men or women sit with each other. Let them have different staircases. Oh my goodness, this person is talking to that one. This is not about consensual friendships, relationships, or even sexual relationships. This is about abuse. And so therefore, we have to remember that the workplaces don't belong to men. I'm saying this the second time because when there was the case that an intern in the Supreme Court talked about sexual harassment, very learned judge said that, okay, we're not going to hire women interns, as though that place only belonged to men, and women were, in that sense, they were, they were peeking into that place, so they were coming and appropriating a place that did not belong to them. So we really have to equalize these particular spaces between men, women, actually all genders. We have to reach much further in terms of accommodating trans and intersex people. Now, even in professional bodies, many times, the people gathering at the bar, I have had gynecologists and other people talking about how all the decisions get taken there and women are left behind. So I would end with saying that CEDAW, the Convention on the Elimination of All Forms of Discrimination Against Women, talks of 3 pillars. One is non-discrimination, that has to happen at the workplace. Substantive equality, is there transport? Are there situations, that force women to leave, and how they can maintain that? And of course, the state obligation to see that the starting line is fair, that the obstacles are removed, that the playing field is equal, and that we're constantly monitoring results, access, opportunity, and results, so that we can really say that through this equitable approach, we have been able to reach individual and social justice, and also substantive equality as a legal measure, that can be monitored and documented. Thank you very much.
Thank you so much, Manisha. Again, so many insights from you there. With that, we sort of come to an end to the formal panel, but we now open up for questions. And we have a question from Neha, who's part of the WomenLift team, who says, with the Me Too movement, a lot of cases came into light as a hindsight. Women got the courage to talk about what happened to them well in the past. Similarly, with regard to GBV at the workplace, how do we ensure that cases that have happened in the past get highlighted today, or at least get spoken about? So do you think it's time to start a similar movement? Asks Neha. So I leave it to you. Who wants to take this question?
I think I mean, I'll just quickly respond to say yes, anytime, Neha, but we also need to remember, where is the Me Too movement today? I think somewhere along the line, this is very, very pervasive, right? It can't be a flashpoint movement and then silence. This movement needs to start, like I said, at the individual level, in the spaces that we are in. And it has to be a sustained long-term process where it builds up to something bigger and more impactful. But I mean, yes, let's start yesterday, you know.
Thank you, Priya. Monalisha, Manisha, do you have anything to add to that, or can we move to the next question?
I just feel that, it's so difficult for a woman of all the, that all the three panelists talked about to speak of sexual harassment at the workplace. I mean, the stuff that I spoke about earlier is going to cost her the workplace itself. And not often because of the people in the workplace after the act has happened, but because of the community. And so if then a woman speaks about that, I think, rather than ask, are you sure it happened? What clothes were you wearing? Why were you there at that time? Why were you, your duty gets over, etc. I think, to validate and to actually at least go into an inquiry, to be fair to the person who has been accused also, but to conduct a proper, fair inquiry. I think that kind of validation is absolutely warranted.
Thank you, Manisha and Priya. The next question we have is, why does the state employers that deploy a female cadre to empower its healthcare neglect their need for a safe environment? Is it because health work is eventually a form of care work, and care work is something that is always devalued? So who wants to talk about this? Monalisha, do you have any insights to share?
Yeah, can I hear the question once again, Shubha? It was not.
Sure. So the question is, why does the state employers who deploy the female cadre to empower their healthcare actually neglect their need for a safe environment? Is it because health work is eventually a form of care work and care work is always devalued?
Yeah, so regarding that, see, the origin that hiring of a female workforce was that because mostly initially with NHM, the programs are also not designed in such a way that they are taking care of everything, but initially maternal mortality and infant mortality, it was bigger in the picture. So mostly the ASHA and female health workers, they were hired and they were promoted for the care work. And again, there is this gendered role that female are better caregivers and they should be hired for caregiving, and they are like in way they are better caregivers than males. But again, when the time comes to provide security and safety, first thing is that as a nation, we are still in the very early stages of providing like good work and health related infrastructure to our healthcare workers. Not only our country, but there are many other countries also. In developing nations, you will be seeing that all those caregivers, vaccinators, and maternal and child healthcare workers, they have to, and the sheer nature and amount of work and the type of work they are like I'm just giving you one example that for our ASHA workers, they are delivering house-to-house services, but the whole this though with Swachh Bharat initiative, there are community toilets which have been developed, but many a times there are not safe like restrooms or toilets for them, and many a times they just have to go to a to someone's house and they have to request for using the restrooms. So it is not just that, it is not a very superficial problem, but it is not something very deliberate also. But as such, the health infrastructure is lacking so much. We have IPHS standards, but in very less areas, the IPHS standards, I would say, they are up to the mark. So yeah, there is a gendered role, but sometimes it is not very deliberate, but this is because of all the structural and systemic issues we are having for health infrastructure. Anyways, you just can think that the spending for health is the least. So until unless the leadership at higher level also thinks that health is a place where we have to invest more, till then developing like infrastructure in a better way is also questionable. And so these things are like more prevalent, and this is the time when it needs to change, right?
Thank you, Monalisha. We now have a question from Prafulla Shriyan. They ask, what if the community itself is bound by the culture and they have no option to report or no channel to report to? So how do we solve a problem like this? How do we educate them to come forward and still report against their bounded culture? Priya, Manisha, do you want to take this?
Manisha, do you want to come in? Yeah.
I could. So see, at the community level, you're grappling with, as I said earlier, the conservative family, traditional roles. You're also, if you see the whole spectrum, you're also dealing with caste panchayats at one end. And if our village level health workers come from Dalit communities, they come from nomadic tribes, NT-DNT tribes, or they come from, OBC and other marginalized groups. Now, then many of them have caste panchayats, and sexual suspicion becomes the major intervention in the name of honor, etc. So, like you would have the caste panchayats in Haryana, but I mean, we demonize one state, but they exist all over. And MASUM, we have also intervened in so many caste panchayats and, kind of stopped extremely inhuman and obnoxious punishments being meted out to women. So at the village and the community level, there is the Gram Sabha. There are various structures within the Gram Sabha. There is an elected, the PRI systems inside. And the health workers have to grapple with all this. And she is also the bridge between the community and the system. And how to deal with the issues there, where also in more sophisticated form, the same kind of values exist there. And so therefore, obviously working with the community, working with children since they're small, since, as early as possible, young married couples before violence happens, all this inside and outside the health system is actually what we require to see that, if violence happens inside the house, it's going to happen outside the house, including the workplace. And if it's outside the house, it's going to come here. Also, in terms of, involving different stakeholders, I spoke about the safety planning, and then we did training of women's and girls' right to safety in public places with the Maharashtra State Road Transport Corporation, 210 drivers, conductors, depot managers, etc. And then they were completely shaken up. They said that, we see this happening in the bus, but we think maybe like it's a lover's quarrel or whatever. Or she was talking to him yesterday. Why is she outside here? It's not her workplace. It's not her, she's not going to college. So to respect mobility, to respect, the basic human rights of all women in this whole continuum of family to community to workplace, because they're not actually very different. You find the same manifestations in different places. So thank you for the question. I think, really, we have to work at community level, but that won't work. You require a commitment to investing in healthcare for safety of all its people, and also to protect rights, not protect people, but protect rights of all healthcare providers, including women. Thank you.
Thank you, Manisha. We have a couple of questions more, but I think we've reached time. So we want to end the webinar today. First of all, we want to thank everyone for being here, as part of this insightful and critical discussion on tackling gender-based violence in public workspaces in India. We are deeply grateful to our three panelists, Priya, Monalisha, and Manisha, all of whom have shared their expertise and experiences with us today. Your perspectives have really shed light on the multifaceted nature of GBV, particularly in the public health sector, and maybe has given us some insights that particularly about the systemic issues which are at play and the steps which are needed to address them. A special thank you to all our audience for your time, for your attention. We hope you leave today's session with some new knowledge, a renewed commitment, and some practical tools to help make workspaces more effective and equitable for everyone. We look forward to continuing this conversation and working together to tackle gender-based violence in workplaces. Thank you so much. Have a wonderful evening. Goodbye.
Thank you.